I'm going to talk a little bit about cardiovascular imaging, and the title is grander than the talk is going to be. Try to sort of stick to the basics just so you sort of have some idea of what you're sending your patients to when they come to us. My disclosure is not very relevant to this talk. So cardiac imaging, I guess there's a few ways to look at it. One way is by modality based, can talk about ultrasound, nuclear, CT, MRI, etc. The other way is sort of by disease process, and imaging really touches all cardiac diseases, as it touches really most diseases, just sort of period. And that can be coronary disease or valve disease, muscle diseases, cardiomyopathies, electrical abnormalities, congenital heart disease, vascular problems. And that's all of this is really much more than just one talk. So in the end of the day, what I think I'm going to do is I'll really focus on imaging for cardiac diseases, talk some about stress testing, some about cardiac CT, and if we have time at the end, I'll spend a few minutes on viability, and I hope that that's a good start. And I'm happy to come back and talk about other things later on if that's of interest. So the issue with us these days is there's just a plethora of testing. So I guess the question is, which test is right for the right patient and which test is right for the right clinical question? And I'll try to answer some of those questions as we go through this. So as I said, we'll talk about coronary artery disease, ischemic heart disease, and I'll start with a few stats, not to make too much of a point of this. I think everybody knows these stats very well, but coronary artery disease is just common, right? So if you look at cardiovascular disease prevalence in the population, when you get to patients greater than 80, or the population, not patients, but the population greater than the age of 80, then really the vast majority, almost exclusive, almost everybody has some sort of cardiovascular disease, you know. And as you get younger, I mean, looking at 20 to 40-year-olds, people you think don't really have cardiovascular disease, you see it's still not an insubstantial proportion of the population, right? 30% of males, almost 20% of women. So even in younger populations, just a common problem. Leads to a lot of deaths and morbidity. You know, if you look at what it is, you know, we get very excited about a lot of these other things these days. We're very interested in heart failure and advanced heart failure therapies, and I know you guys had a very nice lecture about that very recently. You know, we're interested in valve disease, but coronary artery disease is still sort of the biggest chunk of everything that we do. And it's important to remember that. And it's still, you know, cardiovascular disease in the end of the day, still the leading cause of death, sort of across all ages. And you can see certainly in the older population, but really across all ages, very important condition. So not to belabor the point. The one other comment that I'll make is my talk today is really focused on imaging in stable coronary disease. And the reason that it's focused on stable coronary disease is because of data like this, that if you have a patient who presents with a non-STEMI, if you pursue an invasive course of therapy as opposed to a non-invasive course, your patient will do better. And that difference happens pretty quickly from almost the get-go. So if you have somebody coming in with acute coronary syndrome, what you see us do is proceed with interventions. And that's because of data like this, and therefore imaging plays less of a role in this particular scenario. So I'll focus on the other type of disease, which is stable coronary disease. And the question is, what do you need to know? Well, you want to get the diagnosis. Does the patient have coronary disease as the underlying diagnosis? You want to get the prognosis, and then you want to understand what to do about it. So where can imaging help you with that? So we'll start with stress testing, or the sort of the concept of evaluating for ischemia. So there's a bunch of ways to do this. You can do an exercise tolerance test, basically just place the patient on the treadmill and look at the EKG, look for symptoms. And then we have nuclear, echo, CMR, and cardiac CT as options beyond that. So part of the problem is now that we really have too many choices, right? The paradox of choice. If you have too many choices, you really just get frozen and you don't know which one to pick. So less choice is more in this particular case, and we'll try to delve down and try to narrow down what we're going to pick. The other thing that I'll mention about stress testing is the following, that there's this underlying concept that we use, which is what we call the ischemic cascade. And I'm not convinced that this is 100% actually correct, but it's a good framework to have sort of as an underlying framework and to think about as you're considering things. So as you have a lesion and as the lesion severity in the coronaries gets worse, it has various abnormalities that come, and they come generally in a somewhat sequential fashion. So initially you get flow maldistribution, then hypoperfusion, so the territory gets less perfusion. You then start having diastolic dysfunction. You then move on to systolic dysfunction. After that, you get EKG changes, and lastly, you get angina, you get chest pain. So if you think about this cascade and you sort of take it as generally having a reasonable underlying hypothesis here, so how does this impact how we think about things? Well, hypoperfusion is going to be seen best by something that tracks perfusion, and nuclear stress testing, which we'll go over in a moment, is sort of our classic test for that. If you're thinking about systolic dysfunction, well, that's where echo comes in. So in theory, echo should identify coronary artery disease when it's more advanced, further down the line from a nuclear test, which should be more sensitive than an echo. And the data bears that out to a degree. A treadmill test is going to be EKG changes. That's going to be less sensitive than a stress echo or stress nuclear. And finally, angina, waiting for the patient to get chest pain with exertion, in theory, will be the least sensitive. Now, again, there's really overlap here. Things aren't as simple as is stated here, but this underlying concept, I think, is helpful. So let's talk about nuclear testing. And before I show you what a nuclear test really looks like, as it's shown in this slide, I'll go through a hypothetical, sort of simplified model, and we'll come back to this later. So a few things to think about in nuclear. Nuclear is not one thing. Nuclear is many different things. There's SPECT, single positron emission computed tomography, which is the most common type of nuclear stress test we do. We do mostly technetium, 99 metastable, that's the M at the end. So mostly we do technetium scans, but we do some thallium scans. And then there's PET scans that you can do. And I'm going to differentiate, again, these things are in many different flavors. All PETs aren't created equal. These examples that I'm giving you here of rubidium, O15 water, and M13 ammonia are all perfusion tests. So they track blood flow, which is what we're talking about. This is going to be very different than an FDG PET, which tracks metabolism, and we'll talk about that when we get to viability. So these are all techniques for tracking blood flow. And as we talked about the ischemic cascade, blood flow abnormalities are relatively early on in the course. So how do we do this? You can exercise the patient. You can use a treadmill versus a bike. In the United States, we pretty much use treadmills exclusively. Bikes are more common in Europe. People are more comfortable with them than they are in the United States. So you can have a patient walk or ride a bike and exercise. Advantages to that are you get great prognostic data and you get additional stress data. You're not only getting the imaging data, you also get information about their exercise capacity, about whether they have EKG changes, about whether they have chest pain with exertion. So a lot of good information, and if your patient can exercise, getting a nuclear stress test with exercise is preferred. If your patient cannot exercise, bad knees, bad lungs, etc., then we move on to a pharmacological stress test. The nuclear part is the same, whether it's thallium or technetium, etc., but no exercise is needed. We use a vasodilatory agent. Regadenoson is the most common one that we use now, although others are available. Alternatively, we can use a contractility agent such as dobutamine, but that is very rarely done these days. You only do it in cases where all of the vasodilatory agents are really contraindicated. So why would we pick a nuclear? There's good data behind it. Really, the largest papers that exist on the utility of stress testing are really nuclear papers. So lots and lots of data, lots of years of experience to guide us there. And to be frank, it's relatively straightforward. It's not an easy test to do. You don't have to worry about it. You know, when we get to MRI and CT, for example, you'll see you need to think about, can my patient tolerate the exam? With nuclear, you never have to worry about that. Disadvantages, there's radiation, and we'll talk about test performance as we go on. Test performance in the literature is quite good. In real life, there's some limitations, but generally works okay. So this is a very simplified model of a heart, and I hope that it'll make sense as we go through it. here. And this is my own conception, so again, I apologize for its crude nature. So imagine for a moment a heart with two coronary territories. So you have one left main that then divides into two coronaries. One coronary supplies one side of the heart, that's this rim here, and the other coronary supplies this side of the heart. So two coronary arteries, the heart being, part of the heart being supplied by one half and part of the heart being supplied by the other half. So now imagine the normal situation. So in the normal situation, what you get is blood flow down the coronaries and into the muscle. And it is equal to both sides, and this is at rest. So at rest, we all get around 1 milligram per minute, 1 milliliter flow per milligram per minute, something along those lines. It doesn't really matter what the number is, but you get some amount of flow. And that flow perfuses the myocardium, supplies it nutrients, supplies it oxygen. When you exercise or get a vasodilator, what happens is you dilate the resistance circuit, not these big epicardial vessels, but the arterioles, etc., downstream, and you increase flow. And you can increase flow anywhere from 3 to 5 times normal. So the myocardium gets more flow in that particular case. So that's what happens in the normal situation. You have equivalent flow on both sides, both at stress and at rest, and you get more flow at stress than you do at rest. And that's because the heart needs more oxygen, more nutrients as it's exercising, and that makes sense. So now let's introduce a lesion, let's say a tight 90% lesion in one of the coronary arteries. So let's think about what happens at rest. Well, the normal side very clearly will still have normal flow. There's really no question about that. Nothing has really changed on that side. Everything is good over there. What happens to the abnormal side? So initially you think, well, maybe flow would go down at rest, but that's not what happens. What happens is your body modifies itself. It adapts. So what does it do? It starts dilating the resistance vessels. It starts dilating the arterioles downstream, and it does everything it can to maintain flow at rest at the normal level. So at rest, you actually, despite the stenosis, you actually have normal flow on both sides of the heart, the same. If you didn't, if you had diminished flow, if the lesion was so tight so as to not allow for adaptation, or there is no way to adapt to that severity of stenosis, you're going to have diminished flow at rest, and then you're going to have symptoms, right? The patient is going to have rest angina at that point in time. So we're not talking about that extreme case. We're talking about something below that. So what happens with stress? Well, now you stress the individual, and the normal side increases flow as it normally would. You get, again, dilation of the resistance circuits, and flow increases 3 to 5 times in the normal side. What happens in the abnormal side? Well, in the abnormal side, you've already dilated the resistance circuit beforehand, right, to adapt for this occlusion or for the stenosis. So now what you get is you try to adapt to the increasing demand, and you simply cannot. So the flow does not increase, or does not increase as much as it should. So now you have a difference, right? You have sort of the rest flow on one side, maybe a little bit more, and you have much more flow on the normal side. So now there's a difference in flow in both sides. By the way, please feel free to stop me at any time for questions. I know this is sort of on Zoom, so it's a little bit uncomfortable for that, but just pipe up. So that's one situation, that's ischemia. What about infarction? Well, in that case, you have a complete occlusion of the vessel, so there is no flow at rest, while the normal side has normal flow. And then you exercise, and the normal side gets more flow in it, and the abnormal side still can't get more flow because you have 100% occlusion. So you have, again, a difference between the normal and the abnormal, and the difference could be even more stark than the ischemic territory that we saw before. So that's what we're looking for. We're looking for a defect, and we're looking to see, is that defect present in stress and at rest, or just at stress? And that defines whether there's occlusion, an infarct, or whether there is ischemia, partial blockage that the body can compensate for to a degree. So let's look at this in real life for a moment. So this is what a nuclear stress test looks like. The top line, as you can see, stress. The bottom line is rest. These are short axis slices to the left ventricle. And then we repeat that in long axis views here. So just pay attention to this portion of the heart. You can see the lateral wall here has a defect in it, right? This is on stress. There's a defect at rest. The defect goes away. You see the same thing here. In the long axis view, the lateral wall does not get sufficient flow at stress, but gets equivalent flow to the normal side at rest. So this is a case of ischemia, and this is what stress testing looks like, and that's the concept behind it. So when you send a patient for a nuclear test, that's what we do. That's stress testing via nuclear. What about CMR? Basically analogous to nuclear, but no radiation, uses magnetic fields. What we do there is, again, perfusion. No different than what I said before, but instead of using a radio tracer such as technetium or thallium, what we use is gadolinium, an MRI agent. So this is going to be your heart here. It's not well seen yet because we haven't given any contrast. You then give contrast. You can see it hit the right ventricle. It goes from the right ventricle into the left ventricle and from the left ventricle into the muscle. And you can see how the muscle was dark here, and then the muscle became bright here as the contrast went in, and you can see that it's uniformly bright, very analogous to what we talked about in the nuclear test, uniformly bright, meaning uniform blood flow to all territories. And then here's another example, and I won't walk through all the various steps, but just focus on the middle step. When the contrast gets into the myocardium, you can see there's a perfusion defect out here in the lateral wall again. And that's what it looks like on MRI. So again, the normal territory is able to maintain flow, while the abnormal territory is not able to maintain flow. Again, very analogous to the nuclear test. So that's a stress MRI. Why would you choose a stress MRI? Also has good data behind it, but to be fair, the data sets here are relatively small when we compare them to nuclear. No radiation, that's potentially an advantage. High spatial resolution, you can see if I go back to this, that in the nuclear, the whole wall was sort of missing. Here you can see that the endocardium is missing, but the epicardium is still there. So you really do get better images as far as spatial resolution, as far as being able to see details. And the other advantage is you get a full cardiac MRI. So you get to see function, you get to see the valves, you get to see everything that an MRI gets to see. So there's more information there. Disadvantages, it's more complex than your nuclear scan in some ways. There are MRI limitations. The patient has a pacemaker, has aneurysm clips, or is claustrophobic, etc. And again, as I said earlier, the data sets are relatively small when we compare them to nuclear data sets. What about the stress echo? So stress echo is different, and we mentioned that when we talked about the ischemic cascade. What we do in a stress echo is we're looking for wall motion abnormalities, not perfusion abnormalities. So again, at rest, the walls should all be working just fine because, again, the body has adjusted and adapted to the stenosis and is able to maintain blood flow at rest. And then you exercise the patient, whether it's by exercise on a treadmill or whether it's by giving them a contractility agent such as dobutamine, an inotrope. And now the heart requires more oxygen, more blood flow. You're not able to increase the blood flow beyond the stenosis, and that segment becomes dyskinetic or hypokinetic. And that is, again, related to what we talked about in the ischemic cascade earlier. So stress echo would fall over here in line, and that's what we would see. So what does that look like? I don't have a moving picture for you, but hopefully you can see what it looks like here in the still picture, and maybe we'll just start by focusing on the top row. So this is at rest. You can see in diastole the heart's open. This is a 4-chamber view, so lateral wall, apex, septal wall of the left ventricle. The right ventricle is right over here. And in systole, it becomes smaller. The heart contracts. A different view, 2-chamber view. Again, you can see the left ventricle here, nice and large, and diastole, and in systole becomes smaller. Contrast that to what happens at stress, where the heart really does not become smaller in diastole. So the wall is not functional. And I see the hand up.
Thanks, Dr. Weissman. A quick question about the previous slide. So if I'm reading this correctly, you would get a nuclear scan before you would get an echo. Is that right?
No, so the concept would be that the nuclear scan would be more sensitive. You would pick up a lesion even earlier in its course as compared to the echo. And the data sort of bears itself out that at least if you look at sensitivity and specificity data, then we say that a nuclear stress test is about high 70s for specificity, or sorry, for sensitivity, and an echo is low 70s for sensitivity. So slightly less sensitive, presumably because it takes a more severe lesion to be picked up because you have to keep it along in your course. The contralateral does not have to be true, but turns out to be true, which an echo is a little bit more specific. And that's not because of this, it's because nuclear is a little bit more prone to artifacts, and those can fool you.
And I'm guessing in your experience, in some scenarios, you may get a nuclear test earlier for another reason and then find some hypoperfusion rather than the other way around.
Yeah, so you could, I mean, people get nuclear stress tests for all sorts of reasons, and sometimes it's not 100% clear what that reason was, and and then you're left with the result that you have to sort of figure out what to do with.
Got it. Thank you.
And at the end of all these various stress tests, I'll give sort of my general take on the approach. So echo, again, no radiation. It's very different than the other two tests, right? The other two tests I said were perfusion tests. This is a function test. It's really quite different. And like MRI, you get an echo, which is a very powerful test. Lower sensitivity, we just talked about that in relation to that. And again, less data than nuclear, probably more than MRI, but the data seems to be very supportive. All right, so those were all stress tests, MRI, CT, echo, a little bit different flavors, but in the end of the day, they're indirect tests for coronary disease, right? None of them actually look at coronary disease. What they really do is they look at the downstream effects of coronary disease on muscle function, perfusion. CT is a very different test. It is not a stress test. It's just a way to see the coronary disease itself. So what does it look like? This is a coronary CT here, left main, right coronary artery, circumflex, LAD, etc. You can see, you just see the coronary arteries, right? And this is just a very pretty example. The test we did a long time ago, but it's just a pretty one of just a normal coronary tree, right? And it's very powerful. You see them, the coronaries are there, they're normal, no questions about it. What about non-obstructive disease? So I'll just focus on the middle panel and ignore the other ones for just a second. But if you focus here, you can see here's the vessel, and you can see that there's a little bit of an indent right there with a little bit of plaque outside of it. If I can convince you, there's sort of a hill of gray material there. That is atherosclerotic plaque, non-calcified, and that is the beginning of coronary artery disease. It's not causing a severe stenosis. If you put a patient on a treadmill, if you did a nuclear stress test or an MRI stress test, whatever, it'd be normal, right? There is no obstruction to flow. The patient won't have any symptoms, but they do have atherosclerosis, and that's an important finding potentially. What I showed you so far was non-calcified disease. We know that as atherosclerosis sticks around for a while, it becomes calcified. This is a little tiny calcified plaque. You can see it here as well. But again, causes no stenosis whatsoever. So again, you can see the disease, you can characterize the disease, a lot of information. Here's a severe disease. So again, the coronary artery starts here, goes all the way down, continues, and you can see here there's this very large mound of atherosclerosis. You can see this has what we call negative remodeling. So it doesn't respect the wall of the vessel. Not only is it encroaching the wall of the vessel this way, it's also bulging out the other way, right? It's it's pathological remodeling, basically. So a bulky atherosclerotic plaque, and this patient could have symptoms with exertion, right? There's a tight stenosis, and in theory, if you did a stress test, you would have a positive stress test if everything worked out the way we would expect, showing ischemia downfield from this lesion. Even more disease. This is the left main going to the LAD, but I'll focus on the circumflex. You can see there's a coronary here, a lot of calcium, and suddenly you just don't see the vessel at all, right? I can't show you contrast anywhere in here. It's a little bit of calcium strewn in, no vessel, and then the vessel reconstitutes itself down here, this sort of L shape down there. So this is a long segment of occlusion here, and then reconstitutes via collateral. So again, you can sort of appreciate why this is a powerful test. You just see the vessels, you see what's going on. It's appealing. Just one or two more examples just to finish off here. This is an example of a stent. You can see on the cath There's the shadow of a stent here, and you can see that there's multiple stenoses within the stent, and you can see similar stenoses within the stent in the CT. I hesitate to show this picture. This is about as good as it'll get. CT for coronary stents is very unpredictable. Often we cannot see inside stents very well. But in the best case scenarios, this is what you get. High correlation with what you see on the cath. And lastly is CABG. This is a patient with 2 bypass grafts. You can see one here and another one here. This one has a stent in it. Here's a picture of the stent. You can see why it's a little bit hard to read in the stent. But if you look at where my yellow arrow is, there's a little bit of black stuff right in this portion of the stent. And when you look at the angiogram, you can see there's a severe stenosis right in that same region. So this is what CT does. It's just an anatomical test. There is no physiology. I can't tell you anything about blood flow. I can't tell you anything about motion. But what I can tell you about is what the coronaries look like, which was the question that you were asking in the first place. So advantages, you see the coronaries. Second advantage, you identify non-obstructive disease. Maybe that would lead you or the patient to act differently, even if the chest pain is not related to obstructive coronary disease. Disadvantages, it's a CAT scan, so there's radiation, there's contrast, there's limitations of body habitus and heart rate. If the patient is very large up top, if their heart rate is very fast, all of those things get in the way. So there's potential limitations there. All right, so is there a winner? Should we pick physiology, stress testing, or should we pick anatomy, CT, basically? So there have been a few studies trying to answer that question. This is the PROMISE trial, which is a few years old now. And what they did was they took patients with anginal symptoms, or at least what was thought to be anginal symptoms. They randomized them either to get a functional test, a nuclear test, or a cardiac CT. And then they followed them over time. And the answer was it didn't matter. Either one of them was fine. They both did the same. The main criticism of this trial was very low event rate. You can see that after over 3 years, the event rate was only 3.5%. So 1% events per year, that's pretty low. So it's very hard to find differences between tests when people are doing fine. It doesn't really matter what you do. They do okay. But for whatever it was worth, this was a very large trial. You can see the number of patients in each group, about 5,000. No difference. Either strategy was appropriate. There was a second trial that asked the same question. This one is from Europe, from Scotland, called the Scott Heart Trial. Again, they randomized people to CT versus standard of care. So standard of care was not necessarily a stress test. It was whatever the doctor wanted. If it was a stress test, then that's what they got. But if they thought medical management or clinical decision-making, that was fine as well. And CT won in this particular case. If you got the CT strategy, you had less events than if you had standard of care. Now, why the difference between the two trials? There's a lot of discussion about this. Again, standard of care here is not a stress test necessarily, although the majority did get one. In the PROMISE trial I showed you before, the other arm was a stress test for everybody. That's one thing. The second thing is the event rate is much higher. The percent of the patients that had coronary disease in this trial compared to the PROMISE trial was a much higher percentage, so more event rates. And the general idea was that they found a lot of non-obstructive disease in Scott Heart. So the thinking is that Scott Heart is the difference is driven not by the obstructive disease, but rather by the non-obstructive disease, that people saw it and then reacted to it, presumably with better medical therapy. So those are the two trials that looked at, well, which strategy should I do first? If somebody comes to me with chest pain or an anginal equivalent of one sort or another, should I pick stress testing? Should I pick a CT? I think that the data there suggests the CT may be superior. It's not 100% clear since you have two trials that show you slightly different things, but it's not that stress testing is bad, right? In the PROMISE trial, stress testing was just fine. So you could really go with either if you wanted to. And again, we'll go down at least my pathway a little bit later on. So does ischemia matter? That's a slightly different question, right? It's not, is my patient's angina related to ischemia? Is if my patient has ischemia, well, what should I do about it? It doesn't matter. Should I go for revascularization or should I just do medical therapy, assuming that everybody gets medical therapy one way or the other? So there have been multiple trials to this. This is a very an important trial from Rory Hakimovich et al. That looked at this, and what they showed was that if you had large ischemia and you had medical therapy, you did worse than if you had revascularization. And vice versa, interestingly enough, if you had very little ischemia, medical therapy was better than intervention there. And this is what you can see from back in 2011. And at the time, that's sort of what we had available to us. There's a big problem with this trial. It's retrospective, right? So there's no randomization. Why would somebody with large ischemia get medical therapy? Well, they must be very different than somebody who got revascularization. And you can't fix that confounder. So some of this difference that we're seeing may be related to the ischemia, or it may be related to the fact that the patients are just different. Hard to be sure. So have there been trials looking at ischemia? So there have been a few now. The FFR is an invasive equivalent of ischemia testing. So basically in the cath lab, we put a wire beyond the lesion, we measure pressures distal to the lesion, proximal to the lesion, we give a vasodilator, and we watch for a pressure drop. If there is a significant pressure drop, then the lesion is significant. And this is sort of an invasive way to get that physiological information. Why do I show you this? Because the trials that have looked at this FFR guided approach did better than an angiographic guided approach, right? So if you didn't just go by what the angiogram said, oh, that's a severe lesion, but rather you got physiology, right? Stress testing of one sort, or, you know, of an invasive sort. Doing that was superior to using just anatomy. So this would suggest that ischemia is very important and that you should decide what to do based on ischemia. And then there's the FAIN-2 trial. I won't go through the details there. There was similar signals there. Does non-invasive stress testing, is that equivalent to doing invasive stress testing, this FFR? So this is a trial from England looking at cardiac MR stress versus FFR, and the results were basically the same. So you can take them maybe to say that they're equivalent, that we can think about them similarly, which maybe makes sense considering they're at least supposed to be testing the same thing. So that's reassuring that maybe we can use that FFR data as we're thinking about patients. And then a year or two ago, the ischemic trial came out. It was the largest trial looking at this, and it approached things from the following perspective. It took patients with ischemia, moderate ischemia at least, and randomized them to medical therapy versus intervention. There's some other steps along the way to sort of do quality assurance and make sure we're not shortchanging patients of therapies they need, but that's sort of the bottom line. And what they basically showed was no statistical difference between the invasive group and the conservative management group. What you can see is up front, there's a little bit more a price to pay for a procedure, which makes sense. And then over time, maybe you start seeing a benefit, maybe, but statistically, that's not, that does not pan out anyway. However, the interesting thing about this was as follows, that if you break down some of these outcomes and you look at MIs specifically, what you see is the post-procedural MIs, meaning you take the patient to the cath lab, you do a procedure, and then there's a troponin positive the next day. You had more of that in the invasive group, which makes sense. You're doing a procedure that could lead to a little bit of stuff going downstream or whatever and lead to a troponin rise. So that's not necessarily unexpected. Interestingly, for spontaneous MI, meaning MIs that just sort of happen while you're out there in the garden doing whatever you're doing, the invasive arm was superior, which was a very interesting finding. So the overall trial was a negative trial, but this finding of reduction of spontaneous MIs is an interesting finding. So maybe ischemia does matter at the end of the day, at least from this perspective. The bottom line is, again, event rates are relatively low. Medical therapy is doing a good job, all in all. So after all of that sort of background data, where do we stand and what are we thinking? So if we sort of take all the stress tests and we put them in one bucket, and then we take CT or an anatomical testing on the other side, you can see that CT identifies non-obstructive disease. It has a very high negative predictive value. If it's normal, it's normal. That's very helpful. There is a higher angiography rate. If you do CT as your first test, more patients will go to the cath lab. You see more stuff. Disadvantages, radiation, contrast, artifacts, some non-evaluable segments, overcalling based on anatomy. So sort of what we talked about in FAME, where if you use purely anatomy to make the decision whether to revascularize or not, that may not be providing patient benefit necessarily. higher angiography rate, and it's a still image, you don't get function. If you do stress testing, you can or cannot give radiation. Again, if you pick nuclear, MRI, or echo, you get a functional evaluation that's helpful, lower angiography rate. Radiation, again, nuclear on that size. You only see severe stenosis, so you don't see non-obstructive disease. Lower negative predictive value for any one of these tests compared to cardiac CT. They also have artifacts. They're different, but there's artifacts there. And we already mentioned the lower angiography rate. That's an advantage and a disadvantage. Why? Well, if you needed the cath, then maybe not getting it was a disadvantage if there was really a severe stenosis there. So how do I look at it? Well, I guess a few slides on that. So one thing is a well-performed CT gives you certainty, right? If you just know, if it's normal, it's normal. It gives you non-obstructive disease. And if you go on to send the patient for a cath after the CT scan, there's a lot of data to suggest that your cath is much more likely to be positive and your patient is much more likely to get an intervention than if you use the stress test. Rapid turnaround, right? The CT we know is a pretty quick test. What it doesn't do is it doesn't give you functional information, nor does it give you the functional significance of the stenosis. And in patients with calcium, coronary calcium stents and bypasses, the level of uncertainty goes up. So what do? Lots of choices, lots of things to do. You don't have to read any of this. So that's not the point of this, right? This is from Pam Douglas, who's at Duke and really one of the world's experts on this. And this is a flow sheet that they put together. This is complicated, right? In the end of the day, there's a lot of different boxes to think about. Practically speaking, people have a hard time with this type of thing. That's not necessarily helping. So when it doesn't make sense, how do you proceed? This is how I do it. And I don't know that it's the right answer, but it's certainly been my answer based on what I've seen in the data. So I prefer CT if it's a lower intermediate risk patient. If there's no known CAD, again, the more calcium and stents and those things, the worse the disease becomes. If the heart rate is stable, CT is very influenced by heart rate. So somebody who's constantly tachycardic at 100, 110 is not a great candidate for this. If you have a high quality CT center that can do low radiation techniques, and if you need certainty, right, you just need to have a definitive answer for the patient. I prefer stress testing if I need other information, how are the valves doing, what's the ventricle doing, etc. If there's known CAD, stents and bypasses, if I want to avoid radiation, young people, for example, or if the heart rates are irregular. So that's been my approach to it. The bottom line is it's complicated. I'm not sure I know what the right answer is necessarily, and I'm not sure that there is a one and only right answer, but rather each patient, you sort of take it as they come. And with that, I'll stop for a moment. I've got a few slides on viability testing, which I can talk about now, but I'm happy to take some questions about what we've talked about so far.
Hi, Dr. Weissman. This is Yaakov. I'm one of the med students. I did have a quick question about FFR. So is it sort of standard now if you find any lesion, regardless of its size, to just do FFR while you're in the cath lab just to see if you should stent it or not? Or is it sort of case-by-case basis?
Yeah, it's not common still. That may be financial, it may be other reasons for it, but if you look at the rates of FFR in the United States, they are pretty low, single digits, I believe. So we pick and choose, right? You look at the clinical scenario, you look at the lesions, and you try to put them together. If everything adds up in a direction, you may choose to be done. If things don't add up, then I think FFR will provide a lot of benefit.
Got it. Thank you.
Any other questions? The last comment that I'd make about all of this stuff is, in the end of the day, do what your institution is good at. You guys are Georgetown. Georgetown has great testing of all of these modalities, so you can really pick any of them. You may be in some place where one technique is clearly, has more the institution has more expertise with that technique, and then in that case, that may be the right technique to go for, assuming other things sort of are reasonable in that direction. All right, maybe for just a few minutes, we'll talk about just a little bit about viability testing, and I think with that we'll stop. Seeing my slides okay again?
Yeah, we can.
Yep, we are.
Great. All right, so we'll talk about viability testing. I will mention this is a really nice review article from a few years ago now that goes through this topic really in great detail. So what is viability testing? So the concept is as follows. So you have a patient, they have a reduced ejection fraction. These things must be true. They must have a low ejection fraction with wall motion abnormalities, and they have CAD with obstructive disease. And what you want to know is, will revascularizing the patient benefit? And the concept being, if the wall is dead, revascularizing dead tissue isn't helping anybody. So why would you do that? But if the wall is alive, then you would. So why does it only apply to low EF patients? Well, if the heart is squeezing, then it's alive, right? So if you have a patient with bad coronary disease and a normal ejection fraction with all the walls squeezing just fine, there's no reason to ask a viability question. The muscle is alive, it's working. If the anterior wall, for example, is out, it's akinetic, well, now you have a question, right? Is that alive or is it dead? Will I get benefit from revascularization? So that's the concept where viability comes from. This article that I mentioned gives this one slide as an answer. I don't actually like this answer very much. I think it's overly simplistic, but that's the one slide answer. Let's go through the details a little bit. So why is this question coming up? This is old data. The CAST trial is from 1990, you can see, published then, so long time ago. And what they showed was as follows, and it's interestingly enough stayed reasonably similar to this very day, that if you have a normal EF and you have coronary disease, medical versus surgical therapy, there's not a lot of difference. Again, talking about stable coronary disease patients. If you have a low EF patient, then surgical therapy is better, right? Those patients that are at higher risk, they're already suffering damage from this condition, so revascularization makes sense. So if somebody has a low EF and coronary disease, you really do want to revascularize them. But again, maybe there's something buried in here. Maybe there are patients that don't benefit, patients where, again, the muscle is already dead. So maybe you shouldn't think about it so much. So what is viability? Viability is this concept of hibernating. So presumably protective adaptation to low flow and ischemia. So bottom line is you have a stenosis, maybe even an occlusion of a vessel, and the muscle there is getting very little flow. So if it tried to just continue to function normally, it wouldn't be able to do so. There isn't enough nutrients and oxygen and the like to sustain normal cellular function. So what does it do? It sort of dials itself back. It starts to turn down the cellular function and just take the bare minimum that it needs, and therefore there is no squeeze in that area. There is no contraction of the myocardium in that area because there's been an adaptation, again, for the cells to try to protect themselves. Stunning is a different concept. Stunning is in the setting of an acute MI. You release the acute MI, you open up the vessel, blood flow hits the myocardium, but the myocardium doesn't recover immediately. It takes it a while, a few days, a few weeks, etc. That is the concept of stunning. So very different than hibernation. Stunning is in an acute MI with revascularization. Hibernation is chronic coronary disease with a severe stenosis. You can check viability out a lot of different ways. I really won't go through all of them here, but basically almost every imaging technique has some way to do that. How are these tests? There's differences between them. You can see these different colored bars are different techniques. FDG PET, you can see, sort of stands out here for sensitivity. Dobutamine stress echo stands out here for specificity, etc. But generally speaking, sort of within a ballpark, right? So all of them are potentially appropriate tests to use. Why do we care? Well, trials like this make you care. That here, for example, is we have patients who are treated medically versus interventionally. Incomplete revascularization, CR is complete revascularization, non-viable is not viable, V for viable is viable. And you can see that V for viable complete revascularization, for example, does maybe a little bit better than not viable complete revascularization. So some signals to say maybe revascularizing viable tissue is important, but I would caution you, if you look here, you can see the number of patients in each group. It's minuscule, so hard to make conclusions off of these kind of trials. There have been a few trials looking at this. This is a PET-based trial that looked at using PET versus standard of care. And you can see that the p-value is not significant, but it sort of seems to trend to an improvement to using PET viability here. Interestingly enough, if you looked at adherence, meaning if the doctor acted upon the results of the PET the way you would expect them to, then there was a benefit. Then the p-value became significant, and again, the curves separate, sort of similar to what we saw before. So maybe doing PET viability helps. The other trial that the people always mention is the STICH trial. It's a large trial, international trial, predominantly out of the United States. And what it looked at really was medical therapy versus CABG for multi-vessel disease with a low EF. And what you can see is if you do 10-year follow-up, there's a benefit to bypass surgery over medical therapy. But it takes it a while, right? I mean, you can see the first 2-3 years, there's really no difference between the groups. You have to go out for a while. The patient has to have long-term survival to get benefit from CABG over medical therapy in the setting of low EF and multi-vessel disease. But the interesting thing from the point of view of our discussion was that they looked at viability. So if you did not have viability, you did worse than if you did have viability. So viability is good. Having viable tissue by whatever imaging technique you want it to be is a good thing. The problem came into looking at the interaction between viability and revascularization, and it just didn't matter. So having viability, it didn't matter if you picked revascularization or not. Not having viability, the same thing. This would suggest that yes, viability is important in prognosis. What is not important is deciding on therapy. In both cases, surgery may be appropriate. And you can see here how that looks. CABG may be better in both groups, but you know there's an error bars around it, so they both cross the identity plane here. So no interaction, unclear what to do with that. So that left us with a question, right? We've had this concept of viability, and now we're trying to figure out what to do with that. So what do people do these days? It's very divergent. You'll see people doing all sorts of things. But if you have an ischemic cardiomyopathy with significant CAD, what you see done at our institution, and I think relatively commonly, is if procedural risk is acceptable or low, then generally speaking, people favor revascularization. If procedural risk is high, then people generally favor viability testing to sort of be the tiebreaker there. That's that's a fairly common approach that people have. So people haven't really given up on viability completely, but use it selectively in select population. How do you do viability? There's a bunch of ways to do it. There's nuclear ways to do it. And this is how it looks like. This is a nuclear PET scan. So what you do in this is a little bit different than what we did before, although it looks very different. You do perfusion imaging. So you give thallium or technetium, the same thing we gave before. And what you see is there is no perfusion to the anterior wall here, right? There's a big defect there. The anterior wall, there's an occlusion. It's not getting perfusion. And then you give FDG, right? So we said that FDG is a metabolite. It's glucose, basically. It's used in the body for metabolism. So if the tissue is alive, even though it's getting very little flow, it'll take up the glucose. Given a little bit of time, it'll take up the glucose because there's living cells there that require glucose. So this would be viable, right? There's a perfusion defect, meaning an LAD stenosis, but there's cells that are actively using glucose. As opposed to this one here, where you can see the LAD has no perfusion and no glucose activity. This would be not viable by PET. By MRI, we use SCAR to let us know that. So this is pictures of the heart. We give contrast, we give gadolinium. And if you have transmural uptake, like here, where the whole thickness of the wall takes up contrast, we call that non-viable. And if you have endocardial uptake, as here, right, you can see again the contrast uptake, that's infarction, but you can see there's a whole bunch of black myocardium on the other side, meaning normal myocardium. More dramatic here on this side here, you can see a very small infarction with a lot of viable tissue underneath it. So if there is a lot of viable tissue, a lot of live tissue here that doesn't take up contrast, that's considered viable. And if there's no live tissue, all the just contrast uptake here, then that's considered non-viable. And that's the approach that we do by MRI. And those are probably the two main techniques we use, nuclear and MRI. There's also an echo way to do it, which we do a little bit less frequently here.